appearing as a patch, appearing as a whitish area with a defined boundary. Okay, it is homogeneous, elevated. That is there. Erythroplakia is a similar patch having a defined boundary, non-scrapable, but it is of a red color or sometimes a light brown color that cannot be rubbed off or diagnosed clinically as any other conditions. Okay, now nearly 100% of true erythroplakias have been found on biopsy to represent severe dysplasia, carcinoma in situ, or squamous cell carcinoma. Erythroplakia and OSMF has the highest malignant potential. So erythroplakia and OSMF are like the danger signs of any person who is chewing tobacco. This is a far more dangerous lesion, no apparent gender predilection. For men, it is commonly seen as the floor of the mouth and retromolar region. For women, it is commonly seen on the alveolar mucosa, gingiva, and sulcus mucosa of the mandible. Now, 40 to 50% manifest as dysplasia. As I said that, first there is genetically altered cells, then dysplasia, then carcinoma in situ, and then invasive carcinoma. So you can understand that erythroplakia and OSMF, when they are seen, the person is already at stage 2. I would not say it's a stage 2. I would say that the person is already at the second phase of developing a cancer. Okay. So in the such cases, toluidine blue staining may be useful in biopsy site selection for cases of erythroplakia. Oral submucous fibrosis can see that whenever there is band formation, there is the cheeks they lose elasticity. There is reduced mouth opening and the cheeks reduce their elasticity, and there are band formation in the cheeks, and the uvula is shortened. Then that is a peculiar feature of the oral submucous fibrosis. This is a picture demonstrating that there is reduced mouth opening of the people who are having oral submucous fibrosis. If you open your own mouth and try to insert your fingers, as you can see how I am doing, I can insert 3 fingers of my own in my mouth like this. But for a person who is affected with oral submucous fibrosis, 2 or less than 2 fingers can go in the mouth, which is an indicative of reduced mouth opening, and that is a sign of oral submucous fibrosis. Smoker's palate, this occurs mostly in people who are smoking reverse, like they are putting the burning end inside the mouth, and it destroys the minor salivary gland ducts, as you can see here can appreciate this in the picture. They destroys the minor salivary gland ducts and also makes the hard palate inflamed. The most common malignant lesion of the oral cavity is the squamous cell carcinoma. Now, squamous cell carcinoma is obviously a full-blown invasive cancer, a non-healing cancer or lesion that appears to be fixed to the underlying mucosa, coupled with excessive salivation and burning sensation in the patient mouth. That early detection saves life. Now, this is very, very important. Why we insist on early detection? Because stage 1 is not the first step, genetically altered cells. The second step is dysplasia, and the third step, carcinoma in situ. Till these 3 steps, if the person is being diagnosed, the cancerous cells can be removed surgically as a whole. But once it becomes a full-blown invasive cancer, then it is a high possibility that it does lead to metastasis, and then saving a life is not very possible. So 5-year survival for a localized disease, that is the first 3 steps for a 5-year survival, is 76%. And 5-year survival, if the person is in the last stage, then the metastatic disease, then it is 19%. There's a huge difference when we talk about the survival rate of a localized disease as well as metastatic disease. So a successful screening program will advance at the time of detection from the point with which symptoms appear to some earlier point in the natural history of condition. That is why we talk about it again and again. Early detection. Why are we screening? Why are we going and targeting and checking the mouth of all the tobacco users? Because we want to see at what level the dysplasia has reached to. Okay, That is what we want to check. If the person is there, if the person is having a pre-malignant condition, if the person is having some red patch, white patch, or reduction in the oral cavity, or reduction in the size of opening, then it is basically a sign to stop tobacco use right then and there, and then get back to normal gradually. So the time by which detection is advanced is called as a lead time. This lead provides an opportunity for treatment to gain the upper hand over the disease. Now, once the person is diagnosed with a pre-malignant condition, the treatment and management starts right then and there. So it is started to be managed before the cancer has even begun. So the time that we have gained is called as the lead time. Okay, that is why we have an opportunity to save the person right then and there, rather than allowing the person to go into full-blown cancer. How exactly is the cancer screening occurs? Age 18 years and older with cigarette smoking or betel quid chewing. We screen the person with oral visual examination. If it is positive, then it is referred to hospitals and confirmatory diagnosis is made. And if it is uh, oral pre-malignant lesion or oral cancer, then we registered the patient into National Cancer Registry. And if it is free of any oral cancer, we usually ask the person to go to a tobacco cessation clinic, and then the next screening occurs every 5 years. Okay. What it includes: training, pre-screening to identify high risk groups by means of history, collection of data on addiction and symptoms. What we do is visual screening, brush biopsy, toluidine blue screening, light-based detection systems, chemiluminescence and tissue fluorescence imaging. And how we follow up: we follow up the suspects, check for confirmed cases, and we ask the person to enroll for tobacco cessation. How we conduct the examination: we basically take a routine history of alcohol and tobacco use, and this should be the part of each and every dental visit the patient has come to you for. Okay, and we see if there are any abnormalities, irregularities, swelling, pain, lumps, soreness, troubles in movement, ear pain, anything which is abnormal. Okay, what we need is lighting, mirror, gloves, and some time. We look for extraoral examination if there is any asymmetry involved, any lymph node enlargement, any soreness or any swelling is being noticed extraorally. Then we examine intraorally. The soft tissues are being seen, the lips are being examined, gingiva examined, palate, gums, hard palate, soft palate, lateral borders of tongue, dorsal and ventral borders of tongue. All these are examined. What we are looking for? We are looking for any ulcer, long-standing ulcer. We are looking for any white patch, a blackish patch, or reddish patch. We see the floor of the mouth, we see the base of the tongue, and we see the palate as well. Okay, all these are soft and hard tissues are being examined. Toluidine blue vital staining. It is a chairside protocol, simple and very efficient procedure. Toluidine blue mixed with acetic acid. We apply it on any suspected area. Ask the patient to rinse the mouth with acetic acid again, and then it it becomes as a educational tool to actually show the patient where exactly the lesion is. Okay, where exactly the lesion is. That this toluidine blue basically stains the chromatin or the DNA component, and it stains it darker than the rest of the affected areas, the rest of the normal areas. So we can basically locate the lesion by a toluidine blue staining. Brush biopsy, a very simple oral CDX instrument, we call it. It is a metal brush basically, and we scrape it off the lesion, the suspected lesion that we are trying to confirm, and it is pressed against the lesion. That metal brush is pressed against the lesion and rotated 5-10 times, and then gradually that after rotation, whatever is collected, whatever matter and cells are collected, that are spread on a glass slide, and they are uh, histopathologically examined. Okay. Biopsy technique if we have a suspected lesion, we do a punch biopsy or a scalpel biopsy or a FNAC, take a small part of the tissue along with the adjoining healthy tissue, and then we try and observe it under a microscope with a histopathological examination to see if there is any cancerous activity in that area. There are some chemiluminescence as factors as methods as well. There are Wellscope and the Visilite. Wellscope, Wellscope and Visilite. Wellscope and Visilite basically they emit blue light, okay, blue excitation light. If there is any suspected lesion, and if there is any suspected lesion, that will absorb the blue light and will appear darker. And if there is healthy tissue, then it will reflect the will not absorb the blue light, and it will become orange apple green glow. So abnormal cell will appear blue, and normal cell will appear slightly green. That is the concept of Wellscope and Visilite. As you can see, if there is some suspected lesion, if you can see the lower picture, some suspected lesion, we are not sure if there is actually a lesion, then we can check it with the Wellscope and Visilite to see it as a darker one. So to key home take points, oral cancer is the 16th most common, not the 6th most, but 16th most common cancer worldwide and second most common cancer in India. Tobacco and alcohol are established risk factors. Tissue changes in the mouth that may signal cancer can be often seen and felt easily. And training in simple, painless, chairside, inexpensive, and highly sensitive tests are required to gain the upper hand of the disease. Always remember that I said that there are 4 stages of cancer development. We are trying to catch hold of the patient in the first 3 stages by early detection. That is where the effort is. Okay. So conclusion is that healthcare professionals should be trained to detect abnormal cells during routine checkups. Every encounter with the patient is an opportunity to check the patient. Okay. We should advise the patient to visit a dentist once every 6 months. And if a person who smoke or drink alcohol should go for screening 3 to 4 times a year. A person can also perform self-screening by examining their own oral cavity in a mirror. And if there are any abnormalities and symptoms, they should report it to a doctor or a dentist. Thank you. That's all we have for today. In the next session, we are going to discuss more about the individual OPMD lesions. Thank you.
Thank you so much, Shekhar sir, for sharing your extensive knowledge and insights. Are there any questions from the participants? You can share on the chat box and even ask if there are any questions. So, in between, without wasting our time, I would like to request Ashita Rastogi, uh, presenter for clinical case presentation. I invite her and also their team, Dr. Soumya Shukla, Shivani, Kritika, Shubhodeep, Harshita, Heman, and Ronika. I request Ashita to kindly, okay, she has already started her screen. In between, you can message, if any questions are there, you can message in the chat box till the time Ashita is presenting her case. Ashita, you can proceed with your case.
Good evening, sir. Good evening, seniors and all the participants. Today, I am going to present
Ashita, your voice is
a case
echoing.
of
Your voice is not clear. Are you using any speaker or something? Bluetooth speaker?
Good evening, sir.
Thank you.
Good evening, seniors and all the participants. Since, as sir has guided us, that because of the tobacco use and alcohol use, there has been an increase in the oral potential malignant lesions. There was a case of leukoplakia, which came to our Department of Oral Medicine and Radiology in BHU, and it was managed using laser ablation therapy. Today, we are going to discuss this case. He was a 32-year-old patient with a history with a chief complaint of a white patch on the right cheek since 5 months. On taking his history, he elicited that he had a habit of tobacco chewing since 12 years. He initially used to consume tobacco in the form of surti, that is smokeless tobacco. He started at the dose of 1 to 2 times per day, and it increased gradually over the span of 12 years to 8 to 10 times per day. He also has the habit of cigarette smoking. He started at 1 to 2 cigarettes per day, and it gradually increased over the time span to his current level of 6 to 7 cigarettes per day, and has a history of occasional alcohol use since 12 years. And this was the lesion which a patient stated that was initially the size of a pea when he noticed it 5 months back, and then it increased to its current size of approximately 3 into 1.5 centimeter. There was no significant medical or surgical history. It was not contributory to the case. We gave him initial medication of fluconazole 150 milligram OD for 3 days, and retinol 15,000 international units OD for 20 days, lycopene 4 milligram BD twice a day for 20 days, and alpha tocopherol 400 milligram OD for 20 days. Then we suggested the patient on the first follow-up to undergo laser ablation of the lesion. A diode laser of a routine blood checkup was done of the patient, and everything was normal. Then the patient was advised to undergo the laser ablation therapy. Under local anesthesia. The laser used, the brand name of the laser used was Novolace Dual Wave Endo, Novolace India. The wavelength which was used for the ablation of the lesion was 810 nanometer. It was used in the pulse mode, and the power was 3000 milliwatt. This is the initial lesion, and this is after laser ablation under local anesthesia. The lesion was laser band-aid was done to maintain hemostasis. Then patient was followed up after 7 days of laser ablation under local anesthesia, followed by a follow-up on after 30 days, and then final and third follow-up on 45 days. As we can see, the lesion healed completely, and there is normal mucosa, and normal mucosa replaced the initial lesion. The patient is on regular follow-up, and there has been no recurrence of the lesion so far. He was also sent for tobacco cessation and counseling, and as is stated in the articles, the laser does not reduce. The disadvantage is that laser is not able to reduce the oral malignant risk of leukoplakia, and there is still chance of recurrence and occurrence of oral cancer, and so far he has not developed in a new lesion at that site. Thank you, ma'am.
Thank you, Dr. Ashita. This is a good case presentation. Nice treatment, follow-up done. Have you initially asked the patient for any counseling?
Yes, ma'am. First, we advise the patient to
Yes.
to enroll in the tobacco cessation program,
Yes.
and with the medication which we gave him initially, and then he was advised to undergo laser ablation.
Any remarks from your side, Shekhar sir?
This has been a beautifully presented and managed case as well. Also, I would have loved if they have had a detail about the tobacco cessation activity as well. But that's fine. This if one person cannot do everything, I understand that. But this ablation part, along with the pictures, I really love that the patient has had a good response after ablation therapy. Good case.